We are approaching the end of the course, and I hope you've gained a new appreciation for the importance of research and evidence-based practice in nursing. We began week 1 discussing evidence-based practice, and now we will try to bring it home in Chapter 18, Putting Research Evidence into Practice, Evidence-Based Practice, and Practice-Based Evidence. The learning objectives for this week are to distinguish research utilization and evidence-based practice, to identify several resources available to facilitate evidence-based practice in nursing practice, identify several models for implementing evidence-based practice, discuss the 5 major steps in undertaking an evidence-based practice effort, describe some limitations of the current evidence-based practice model, and discuss the concept of practice-based evidence, distinguish generalizability and applicability, and finally, identify some strategies for enhancing applicability. Evidence-based practice is a decision-making process that incorporates 3 elements: best evidence, clinical expertise, and patient preferences and values. The 3 elements are all important. To have evidence-based practice, you need the best evidence. Throughout the semester, you have learned how to distinguish good from bad evidence. You have also learned that the evidence pyramid, you've also learned about the evidence pyramid that identifies the strength of evidence. Your clinical expertise is equally important. First, it informs research questions and leads to the questions that guide the research. Second, all the research in the world is of no value if it stays in journal articles and is not implemented. We should each be asking, how do we put the research, the evidence, into practice to improve the care of those patients at our facilities? We then ask ourselves, what does the evidence suggest is the best approach to solving this clinical problem? Finally, patient preferences and values are important, and as nurses, you are the ones most closely connected to the patients, and thus in a position to more clearly understand their preferences and their values. During the 1980s and 1990s, there was a move toward research utilization, which pushed healthcare to use evidence to make decisions. No longer did a career depend on memorized facts, but the realization that it was important to continually check for new evidence and the push for lifelong learning. Criticism began to grow about the approach of healthcare providers from people like Archie Cochran. He saw us as failing to incorporate research evidence into our decision-making processes. And he put his criticism into a project that became the Cochrane Collaborative. The Cochrane Collaborative is now an international partnership with participants from almost every country. During the semester, one of the places I encourage you to search for evidence was Cochrane, because they do keep databases of health evidence. They describe themselves as like this: Cochrane is anyone interested in using high-quality information to make health decisions. Whether you are a clinician, patient, researcher, or policymaker, Cochrane Evidence provides a powerful tool to enhance your healthcare knowledge and decision-making. That is their view of what they do. And I find that view very accurate. They are the first place I go when I want to see if somebody has done the work that I'm looking for about evidence about a particular condition. About the same time as the creation of the Cochrane project, McMaster University established a learning strategy called evidence-based medicine that later became what we now call evidence-based practice. We have now progressed to well-funded programs of translational science, which is part of what spurred the DMP programs. Thus, historically, we went from the traditional research and the traditional knowledge that people learned during their education to evidence-based medicine and the Cochrane collaboration to translational science. Knowledge translation is the synthesis, exchange, and application of knowledge by relevant stakeholders to accelerate the benefits of global and local innovation in strengthening health systems and improving people's health. There was a time when you would have never seen research grants for translational science, but now they are common and they are becoming pretty much a normal expectation that you will see as you advance in your careers. Your textbook offers you a list of some resources for evidence-based practice. I am going to list some more for you. One of the ones your textbook talked about is one of the things your textbook talked about is the 6S hierarchy of evidence-based resources. And I have attached that on this slide as some of the resources that they identify. The search for evidence-based resources should begin at the highest possible layer. The categories of evidence-based resources described here correspond to the layers of 6S model. So if you look at the layers and you look at this pyramid is a little different than the pyramid I showed you earlier in the semester about the quality of studies or how much emphasis we place on a study. And at the top of that pyramid was systematic reviews. This is a little different. In this hierarchy, original journal articles are at the bottom, evidence-based abstracts, then systematic reviews. But you noticed that there is synopsises of evidence-based journal abstracts, and above that, evidence-based clinical practice guidelines, and above that, computerized decision support systems. In other words, this is prioritizing and saying what's most important to you when you're implementing evidence-based practice and how you do it to guide your decision-making in your practice. Some of the resources listed were divided down into summaries and guidelines, and you can see the ACP Smart Medicine, Dynamed Plus, Up to Date, which many of us are familiar with, and then Natural Medicine. There are pre-appraised resources such as Cochrane and the ACP Journal Club, BMJ evidence alerts, which have been around for quite some time, and McMaster Plus. And then there's the non-appraised evidence of the primary studies, and this is where you first look for evidence, and those are things like PubMed, Medline, CINAHL, and Embase, which you have all used this semester. One of the things that I want you to think about is evidence-based practice in your own clinical practice. Evidence-based clinical guidelines take a body of evidence, including existing research and case studies and systematic reviews, and they put them in a format that's easy to use. Unlike systematic reviews, clinical practice guidelines give you specific recommendations for evidence-based decision making. Usually, researchers, subject matter experts, and clinicians work together to create these guidelines. A recommended approach is to search in guideline databases or through specialty organizations that have sponsored guideline development. There are two specific places that are recommended to you by your textbook. One is the National Guideline Clearinghouse, and the other is Registered Nurses Association of Ontario. It's important to know that there are many sources for guidelines, and these are just two that we are mentioning to you. When you're doing your searches, you will find that sometimes you can't find a guideline on what you're interested in, and other times you may find multiple guidelines. The quality of the guidelines you find are not always going to be the same. You are going to find some that are good and some that are bad. And usually this is based on the level of rigor that went into creating the guidelines. This is one of the reasons why it's important to appraise them for quality. And all semester you've been learning how to appraise research articles for quality. But you also need to know how to appraise guidelines for quality. One method is, for appraisal of guidelines is called agree or agree to. And it's divided down into scope and purpose, stakeholder involvement, rigor in development, clarity of presentation, applicability, editorial independence. You can find the agree and agree to at the link that I have provided to you. The purpose of agree to is to provide a framework to first assess the quality of guidelines, and two, to provide a methodological strategy for the development of guidelines, and three, to inform what information and how information ought to be reported in guidelines. As with the original instrument, Agree To is designed to assess guideline development by local, regional, national, and international groups or affiliated government organizations. I would highly suggest that you take a look at this. It's very informative and it will help you as you're reviewing guidelines. And until you get really comfortable with it, it's always good to have a tool beside you when you're looking at a guideline. There are multiple evidence-based practice models for you to choose from. And I have a list here that are provided to you in your textbook and a little more information in your book about each one of them. The 6 provided are advancing research and clinical practice through close collaboration model, the IO model of evidence-based practice to promote quality care, which is a very common one that is used in nursing, promoting action on research implementation in health services, diffusion of information model, the Johns Hopkins Nursing Evidence-Based Practice model, which is also very commonly used by nurses, and then the Statler model of research. Which you choose would be entirely up to you and what you're doing. but they all follow the major steps of evidence-based practice. Step one is to ask yourself a well-worded clinical question that can be answered with research evidence. Earlier in the semester, we talked about PICO questions. After you have created your well-worded question, you will need to gather evidence. There are several free search engines, but the one that we use most often is PubMed. And while the search engine is free, it doesn't mean it gets you free access to articles. However, if you work at a hospital or you are taking a class through a university, you will have access to PubMed and other search engines like CINAHL and EvidenceBased. And with all of those, you will have free access to journals. And usually, if the journal doesn't have the full text article, you can request it through interlibrary loan, and you'll usually receive it within 1 to 2 days. You want to check for the quality, and what you want to know is to what extent is the evidence valid, and how serious is the risk of bias. So after you have acquired your search and you've retrieved your best evidence, you then have to start appraising it and critically appraising the evidence for validity and applicability to the problem you're interested in, and the situation involves you thinking about quality, magnitude, quantity, consistency, and applicability. The magnitude really is how large is the effect of the intervention or the influence on the outcome. Remember the I and the O of your PICO question in the population of interest, and the P of your PICO question. Are the effects clinically significant? You also want to know about the quantity. How much evidence is there? How many of the studies have been conducted? And did those studies involve a large number of participants? Remember, you have two types of research studies. You have the quantitative ones and you have qualitative. Qualitative are usually very small. Quantitative ones can be large or small. And of course, the best evidence comes from randomized clinical trials. Those are less common. You need to look at your study to make sure that you know how large it was. And if you remember throughout the semester, I've always been asking you to fill in a table. And one of the things is how many participants were there. You will be looking for consistency. How consistent are the findings across various studies? You're likely going to find multiple studies on either the same or very similar pieces of research. And the question is, are all the studies finding the same thing? Are the findings similar? Or are they vastly different? And that's important to know. And then finally, applicability, which is to what extent is the evidence relevant to my situation and my patients. Remember when we do randomized controlled trials, they're looking at the average person. They are population-based studies looking at a particular population. But human beings are individuals. And more, there's a growing desire for us to not just say, how does a research study that addresses a population apply to that population, but how does it apply to individual patients? We then want to assess and evaluate the outcomes of practice change. it's important to remember when we're doing this that one of the important aspects of qualitative research is it gives the perspective of the patients, and it can identify why patients may or may not complete treatment. So it brings the patient perspective and their values into the mix. So when you're assessing to evaluate the outcomes on practice change, sometimes qualitative studies will help you along the way. There are other types of research perspectives that have occurred over time, and I want to discuss a few of those with you. One is the comparative effectiveness research, and in 2009, the Institute of Medicine issued a report on priorities of comparative effectiveness research, and it offered 6 defining characteristics of this type of research. See, its objective is to directly inform clinical decisions. It places a high value on the ability to generalize results to real-world decision-making. One of the things that we frequently face in clinical care is it isn't a laboratory. All of the things that are very carefully controlled in randomized controlled trials cannot necessarily be controlled on the average hospital unit. CERs also involves comparison of 2 or more alternative treatments, each of which have a potential to be best. It avoids the use of placebos, attention controls, or interventions as comparators in testing an intervention. So it's only looking at treatments that are equally likely to be good. CER seeks evidence at both the population and the subgroup level. One of the goals is to help providers and patients in individualizing decisions, so going beyond average effects to effects for people with similar characteristics. It uses outcomes that are important to patients. So CER strives to include and give weight to patient-reported outcomes and to attend to benefits, harms, and unintended consequences of the healthcare interventions, which means it doesn't just look at the good an intervention can do, but it looks at some of the bad things that can happen and some of the difficulties in completing a treatment. Treatments are not always easy. In fact, sometimes they are difficult and they are unpleasant and they can be painful. CER uses diverse research designs and methods, so some comparative effectiveness studies involve experimental design, but some are non-experimental observations. And then finally, CER is conducted in real-world settings, which means it's not strictly controlled in a facility that is only a research facility where every aspect of the care can be controlled. Let's talk about a few more examples. Other directions in healthcare research include pragmatic clinical trials, which have features designed to maximize external validity with minimal negative effect on internal validity. Subgroup analysis, which involves efforts to disentangle HDEs from subpopulations of people. And finally, precision or personalized healthcare, which has come into favor recently, and it is the interventions can be individually tailored to people based on their unique genetic, physiological, behavioral, lifestyle, or environmental profile. The goal is not necessarily to develop a unique treatment for every individual, but rather to tailor interventions for those with tightly grouped biological and other features. So it moves beyond the population, beyond the subgroup, down to the individual level. The other thing that some of these other methods include is cost and cost effectiveness. We need to always keep in mind that if there are two treatments and they are both of equal value, they both are equally good, then cost may be a decision for a patient. Likewise, if we had a cancer treatment and they both had the same effectiveness, the same 5-year survival rates, and one of the considerations might be cost, but another consideration might be side effects for the patient. How many days do they feel ill? How many other unpleasant side effects might they have? The only considerations should not just be, does the treatment work? Because there are many treatments that work, and they have such unpleasant side effects that people do not complete those treatments. These were just a few things for you to think about. If you have any questions, my contact information is in the learning management system. This was just designed to be a quick summary of evidence-based practice after a full semester of research and evidence-based practice, and to make sure you are aware that we didn't cover everything in the course. There are other types of research methodologies that were not discussed, and the hope was this would enlighten you at least a little bit on a few of them.